Thank you all so much for the opportunity to be here with you today. I'm truly honored to join so many people who are committed to improving care and safety net communities. Again, my name is Dr. Charles R. Rogers, and today we're going to talk about something urgent and practical: how to overcome the real barriers that prevent patients from completing colorectal cancer screening, and how we can advance equity in the process. The session is not just about increasing screening numbers, it's about making sure prevention actually reaches the people who need it most. Before we move forward, I want to share a brief note. Today's talk includes discussions of racism as well as cancer disparities. For some of you, these topics may connect to personal or professional experiences. They can be heavy, they can be painful. If at any point you need to step away, turn off your camera, or take a moment for yourself, please do so. Your well-being matters to me. I appreciate each of you being here and engaging in this important work. Now, let's talk about why this work truly matters. Colorectal cancer remains one of the leading causes of cancer deaths in the United States. This year alone, nearly 159,000 new cases. That's what we can expect, as well as more than 55,000 deaths. That means that someone in this country dies from colorectal cancer every 9 minutes. By the time this session and Q&A are over, we will have lost about 5 people to a disease that is often preventable, treatable, and beatable when caught early. Behind every number is a person, a parent, a sibling, a patient who may not have had access to care, timely follow-up, or trusted outreach. Cancer disparities run deeper than what we see on the surface. Colorectal cancer, or CRC, does not affect all communities the same way. Recent data just released yesterday continues to show that Black Americans still have some of the highest rates of CRC cases and deaths in the country. Only Alaska, Native, and American Indian communities have higher rates. As a Black man, I'm about 20% more likely to develop CRC than a white man. I am also about 40% more likely to die from it. Black women, as you can see, they face similar gaps. They are more likely to be diagnosed and more likely to die compared to white women. Income, insurance status, and where someone lives also shape who gets screened, who gets follow-up care, and ultimately who survives. Again, every 9 minutes, someone dies, but not everyone faces the same risk. There's another urgent trend we must talk about. CRC is rising among younger adults. Since the mid-1990s, rates in adults ages 20 to 49 have increased about 2% each year. Today, 1 in 10 new CRC cases occurs to someone under age 50. As of this year, CRC is now the leading cause of cancer death for both men and women under age 50 in the United States. That's just opposite in our tracks. Recently, we were reminded how serious this disease can be when actor James Van Der Beek passed away at age 48 from stage 3 CRC. As you can see here, he was a husband. He was a father of 6. He shared that he had no family history and he took care of his health. His story reminds us that CRC does not always look the way we expect, and early symptoms are often missed. Behind every statistic is a real person, a real family. Behind every missed screening is a life interrupted. So the question becomes, how do we close these gaps before more lives are lost? We often celebrate the national CRC screening rates are in the mid-70% range. On the surface, that sounds like progress, but averages can hide inequities. In many safety net settings, especially those serving low-income, uninsured, and Black and brown communities, screening rates are often 10 to 20 points lower. And the biggest concern is not just who gets screened, it's what happens after the abnormal result. Nationally, we aim for more than 80% of patients with an abnormal FIT test to complete a follow-up colonoscopy within 6 months. But in many under-resourced systems, that number can fall closer to 50 or 60%. That drop-off is where lives are lost. If you look at the funnel here on the right, you can see where the gap widens. Equity is not measured by how many tests we hand out. Equity is measured by how many patients complete the full path to diagnosis and care. So the real question is, where are we losing patients and why? When I work with organizations on colorectal cancer screening strategy, we often find that gaps in screening fall into 3 main areas. They're either structural, behavioral, or engagement barriers. Let's take a moment to talk about what that really means. First, we need to understand or be reminded of the difference between equality and equity. Equality says we offer screening to everyone. Equity asks, who is not completing screening? Who is not getting follow-up care? What barriers are standing in the way? Equality sends the same invitation to all, whereas equity makes sure people reach the finish line. Equity is not achieved when we send a text message. Equity is achieved when the colonoscopy is completed. An abnormal FINT test without a follow-up colonoscopy is not prevention. It is a delayed diagnosis. If we want to close that gap, we have to understand what's standing in the way. Let's take a moment to break that down. None of us can afford to look away. Where you live, where you work, and how much you earn still shape your health. CRC disparities are like an iceberg. What we see above the surface are the outcomes, typically cancer diagnoses and deaths, but below the surface are the real drivers. These include access to care, housing, income, education, neighborhood conditions, and even systemic racism. Race itself is a social construct, but systemic racism is real. It is built into policies and systems that shape opportunity and health over a lifetime. So this is not just about personal choices, it is about systems. In screening, structural barriers show up in very practical ways: insurance churn, transportation challenges, language barriers, limited colonoscopy capacity, and even referral breakdowns. We cannot message our way out of structural failure, but we can fix systems. For example, closed loop referral tracking ensures no abnormal result is lost. Default fit distribution makes screening the easy choice instead of the hard one. Structural problems require structural solutions. Now, let's move to the next layer. Behavior barriers also play a major role in delayed screening. Common ones include fear, fatalism, mistrust, as well as competing priorities. In some of my research, we held 11 focus groups with 84 African American men across Ohio, Minnesota, and Utah. We met in trusted community spaces, and we asked a simple question: what makes a Black man less likely to get a colonoscopy? You can see that fear came up the most. Fear of pain, fear of bad results, fear of the unknown. Cost, as well as lack of clear information, were also major concerns here. Some men talked about stigma and misinformation. A few even said the procedure felt like a threat to their masculinity. But the strongest theme across nearly every group was actually medical mistrust. One man said it plainly: I don't trust them old white boys. I think about Tuskegee and everything else. Sometimes I don't think they specifically being white doctors, care whether I live or not. That statement is heavy, but it's honest. These are not individual failures. They are the predictable results of history, lived experience, and systems that have broken trust. If we want patients to move forward, we must first understand what is holding them back. Patient delay becomes an even more complex when we look at early onset colorectal cancer. In my I Beat CRC research, I interviewed adults across the country who were diagnosed before age 50. Their story revealed common patterns. One person said, what I thought were hemorrhoids turned out to be stage 3 colorectal cancer. This shows how symptoms are often dismissed by patients and sometimes by providers. Another survivor said, I had to do some soul searching about how I felt about medical professionals. I was treated badly. That speaks to how past experiences shape trust. So, what can we do? First, we can frame our messages around prevention and family instead of focusing only on risk. We can focus on staying healthy for the people who depend on you. Second, we can use culturally responsive scripts. That means clear language, respectful tone, and messaging that reflects the community we are serving. When people feel seen, heard, and respected, they are more likely to move forward. Understanding delay helps us design better engagement. So let's talk about that final layer: engagement itself. When we talk about engagement barriers, it's important to make one thing very clear: outreach is not the same as engagement. One text message does not equal engagement. Timing matters. Behavioral nudges matter. Follow-up cadence also matters. Outreach is often short-term and transactional. We send a message and hope for a response. Engagement is different. Engagement is about building trust and relationships over time. It focuses on community benefit, not just program metrics. In the technology space, the biggest gains happen when we move beyond one-time messages. That means multi-touch messaging, reminder sequencing, user behavioral insights, and digital outreach, tracking data beyond whether a message was simply sent. Technology becomes powerful when strategy drives it. The strongest platforms blend technology with a human touch, pairing automation with culturally grounded messaging and workforce support. When engagement is intentional, screening completion increases, and that is what equity requires. Now, let's shift into solution mode. If we want to reduce structural behavioral and engagement barriers, here are 5 practical strategies that work. First, normalize screening conversation. Screening should not feel awkward or rare. It should be a routine part of care. That's wrong. I didn't mean to do that. When providers bring it up confidently and consistently, patients are more likely to follow through. Second, use trusted messengers. People listen to voices they trust. That might be a community health worker, a faith leader, a peer survivor, or a provider who reflects the community being served. Third, default to action. Make screening the easy choice. Mail the fit kit, pre-schedule the follow-up appointments, remove extra steps whenever possible. Fourth, track completion, not just intent. It is not enough to record that a recommendation was made. We must measure who actually completes screening and follow-up care. Research shows that Black patients are less likely to receive a physician recommendation, less likely to receive timely follow-up after a positive stool test, and less likely to receive high-quality colonoscopy. If we only track offers, we will miss this gap. And fifth, close the loop after abnormal results. As abnormal tests should trigger immediate follow-up, navigation, and support. When we close the loop, we do more than save one life. We protect families and communities. Equity requires intentional systems that integrate with your clinical data, automate follow-up, and support scalable workflows, especially in safety net settings. Let me ask you a simple question. Do you truly know your data? In my own community work, data drives everything we do. One example is a project called CRC and Me, where we launched a community-based media campaign focused on early onset colorectal cancer. We didn't choose locations randomly. We targeted communities living in CRC mortality hotspots, areas where people were dying at higher rates. In Utah, we identified early onset hotspots, whereas in Wisconsin, we looked at data across a 29-county cancer center region to find broader CRC hotspots. Those data mattered. By grounding our work in real numbers and pairing that with lived experience from the community, we were able to design prevention efforts that met people where they were. Data should not just describe a problem, it should guide action. Public awareness campaigns can be powerful, especially in communities that are often overlooked. When we launched this work, projections showed that early onset CRC was on track to become the leading cause of cancer death for people under 50 by 2030. That urgency led to the CRC Me campaign in Wisconsin and Utah. Since we focused on the previous slide of the real hotspot data, the campaign reached more than 26 million people. It also led to nearly 43,000 direct clicks to prevention and screening information. Those number matters. Awareness is often the first step towards action, but awareness alone is not enough. Action is what saves lives. Now let's bring this back to what you can measure and improve in your own systems. In case your organizations, having data is not enough. You need the right data. Bad or incomplete data can lead to wrong conclusions. Here are the metrics, in my opinion, that truly matter. First, your screening initiation rate. How many eligible patients actually start screening? Not just how many were offered it, but how many completed the test. Second, your fit return rate. If you mail out 100 fits, how many come back? That number tells you how strong your outreach and follow-up systems are. Third, colonoscopy completion after an abnormal fit. This is one of the most important equity measures. If patients do not complete follow-up, the screening process breaks down. Fourth, time to completion. How long does it take from abnormal result to colonoscopy? Delays increase risk. And lastly, drop-off points. Where in your funnel are patients falling away? Is it after outreach, after abnormal results, during referral? If you're not measuring the drop-off, you can't fix the gap. Data should show you where to focus your energy and where equity is breaking down. To move from awareness to completion, you need clear data across your entire pathway. That means knowing how many patients are eligible for screening, how many receive outreach, how many are sent a test, how many return that test, and how many complete follow-up care after an abnormal result. Each step matters. If you cannot see each step, there's no way you can improve it. The goal is not just to start screening, the goal is to finish the process. So take a moment and ask yourself, at which step are we losing patients? Once you know the answer, you know where to act. Misprevention, unequal access, and delayed screening still drive CRC disparities. CRC is preventable, treatable, often beatable when found early. We know screening works, but access to screening is still uneven. Last December, I shared that I had my first colonoscopy at age 42 because of family history. That post reached nearly 37,000 people. Many said they had never heard someone talk openly about screening at that age. Some even told me that they scheduled their own exam because of that post. That tells us something. The way we influence behavior has changed. We know what happens when screening comes too late. What we have not done consistently is fix the upstream conditions that decide who gets screened early and who does not. The next frontier, in my opinion, is not more awareness. It is intentional systems change and accountability for completion. If we're serious about overcoming barriers to CRC screening, the next frontier is precision engagement. In simple terms, that means reaching the right person with the right message at the right time. That only works when technology is paired with strategic guidance, strong message design, and operational support tailored to safety net organizations. Not everyone needs the same reminder. Not everyone faces the same barrier. That's where behavioral segmentation comes in. Behavioral segmentation means grouping patients based on patterns: who delays, who forgets, who fears the results, who faces access barriers, and tailoring your outreach to match those needs. Culturally tailored digital outreach also matters. Messages should reflect the language, values, and lived experiences of the communities we serve. That is how we move from equality to equity. And lastly, real time analytics are key. We cannot wait months to see what worked. We need to know quickly where patients are dropping off so we can adjust and respond. As I begin to close, I want to leave you with this: data matters, but stories move people. Numbers help us understand the problem. Stories help us feel the urgency. When individuals and families share their experiences with CRC, the impact becomes real. We see what is at stake. We see what happens when prevention comes too late and what is possible when it comes early. When data and lived experience come together, change happens faster. I want to show you a brief video that captures what it looks like in practice.
It's the second leading cause in death, like for cancer, and we don't talk about it.
And I wanted to just give you guys an image of how anybody could be affected by this. Colorectal cancer affected me through my marriage. My beautiful wife, Shannon Sylvain.
Losing my dad to colon cancer, I feel like if he was screened earlier,
I knew nothing about colorectal cancer until I was personally affected by it, battling stage 4 colorectal cancer. With it being one of the leading causes of death for Black individuals, is at a higher risk if you just don't take the time to put your health first.
Finding out that it's preventable was a big shock, and how talking to our family, asking the right questions, and not being afraid of the procedures, it could save your life.
Colorectal cancer is a preventable, beatable, and treatable disease that no one has to die from. Visit crcequity.org today.
A simple truth that has guided my work for nearly 2 decades: structural, behavioral, and engagement factors shape cancer outcomes long before a diagnosis is ever made. These factors determine who gets screened, who is taken seriously, how quickly treatment begins, and ultimately who survives. Here on the right is my Aunt Joanne. In 2009, she was misdiagnosed multiple times across 2 major health systems in North Carolina before finally learning she had stage 4 colorectal cancer at just 52 years old. She fought for nearly a decade, and we ultimately lost her to this disease. I often think about a hard but necessary question: would her outcome have been different if screening guidelines had reflected what we already knew back in 2008, that Black individuals were developing CRC earlier and more aggressively? Her story, it taught me something I carry every day. Equity is not just access to screening, it is completion of care. This is what happens when prevention comes too late, and it is why we must move faster, listen better, and act upstream. The gaps we discussed today, they're not going to close on their own, but they can close. With intentional strategy, culturally grounded engagement, and structural accountability, we can change the trajectory of colorectal cancer in our communities. Prevention works, screening works, completion, that's what saves lives. Thank you all for the work you do every day to serve patients who are too often overlooked. And thank you for allowing me to share these practical tools to help advance equity and overcome barriers to CRC screening. I look forward to your questions.
Thank you so much, Dr. Charles. That was super informative. Again, for anyone in the audience, I took notes, so I got this all covered. A lot of this will also be sent. And with the last 10 minutes that we have, please ask any questions that you have. I see Anu already. Anu, you're gonna get a golden star. You're always like our top star when it comes to asking questions. So shout out to you. But there is a question, Dr. Charles, in the audience. Is it possible for the providers to start the engagement process with respect to screening for cancers if the patient fits the criteria? And I can make sure you have that question and you can see that question as well. So here we go. Would you like me to repeat the question?
Yeah, so I actually can see it, and
Oh, okay.
so yeah, so it's fine. So it said that is it possible for the providers to start engaging a process with respect to screening for cancers if the patient fits the criteria? Can you give me more details on what you mean in terms of if they fit the criteria? What are you defining as criteria? If they have symptoms or if they're old enough? What do you mean when you say that? Because I see your follow up note says I think to provide a conversation.
Um, Anu, unfortunately, I can't bring you up to the stage. It won't allow me. I'm so sorry.
Okay. So let me try to infer from the comment that's afterwards. So I think provider conversation is missing to actually engage the patient to get the test done. I understand that the lack of time for providers is always a reason for not engaging their patients. Okay. Okay. All right. So let me share some examples of what I've seen and what I like to try to tell people. I think with the health system, as I mentioned today, it like with the insurance term, that I agree, as you mentioned, that a lot of providers may tend to be always just pushing people out. And so, as a patient advocate, I'm really big on reminding people of the power that they have themselves to choose your own provider. And so, if your provider doesn't have the time or doesn't have the willingness to listen to what you have to say, then you fire them and you find someone else. And so an example of this is I have a colleague in Miami, Shannon, and Shannon had to see 20 people, 20 different doctors before she finally found one that listened to her because she knew that her body wasn't right and it was showing all these different symptoms. And so as you can imagine, by the time she went through 20 different people, the costs were outrageous. Her diagnosis was more advanced than it could have been if the first person would have listened to her. But she was one of those early onset individuals who wasn't being listened to. And so I try to sum this up to say that it's indeed possible for the providers to start engaging the process early, but if they start it will depend on what they believe. And so some people are on this same thing in terms of, yes, the best screening is the one that gets done, but also if early onset has been on the rise at about 2 or 3% every year since the mid 90s, maybe I should indeed listen to someone when they come to me and they're perfectly healthy, but they have these symptoms that often are similar to what people with colorectal cancer are going through, whether it be blood in your stool the size of an ink pen. You haven't had to have to have a bowel movement in several days. You've been bloated for for quite a bit amount of time. And so, I think it's very important that patient provider communication is done in a way that it's a two-way street, that the patient is listened to by the provider for the change to happen. Hopefully that answers your question.
Thank you so much. I have a question actually. What if like the patient expresses like fear of like a positive result? What if they're like in that mindset of like I don't want to know, which is not uncommon.
Yeah. For my own work, it depends on the frame. Like the best thing is definitely to respond. And, whether it be through this platform that we're discussing today or from the provider itself, some people deal well with positive framing versus some with negative. And so what I mean by negative is some guys may need to hear that, say it's a Black male. It's like, yeah, I think you want to consider screening because you have a 40% higher chance of dying compared to other people, versus some people may need to hear something that's more positive in terms of like, yeah, getting the screening will make sure, say someone that's Latino, this screening will make sure that you can keep you around for your niece's quinceañera, for example. And so framing definitely matters substantially in terms of how we can influence behavior change, and even just education, whether it be, a lot of people are afraid what they don't know. And so even as I provide the example about me coming public with my colonoscopy, in that post, I also talked about how, everybody's always talking about the prep. I took a way, 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 way not as much liquid prep, and it was actually fantastic. And so when I described that in detail in a way that wasn't like, ew, yucky, like people was like, oh my goodness, I didn't even know. And I was like, again, you just have to advocate. I knew that there were options and I advocated for that. And they had no problem sending that to the pharmacy. And so people don't know that there are options that are out there that are very affordable, that you can still make sure that you get it done in a timely manner.
Appreciate that. I love that you stated that, right? Like framing influences behavioral change at the end of the day. So we have 3 more questions and we have 5 minutes. So we're going to try to get through these. And I appreciate the audience for continuously pushing in questions. Annual visits are scheduled for a longer duration. Would that be the time to really have the conversation to engage the patient to start the process of getting screened?
Yes, I would agree with that is a great time. But I think yes, that's definitely a great time. And this is something that we should continue to normalize outside of those annual visits as well. Since we know this is such a big deal among younger people, this is something that, in my opinion, we shouldn't just have when they're, their annual visits, their 44 and their 45th birthday is coming up. We should have that. It's like, no, if we know that our patients have a family history, we should be saying like, okay, this patient's coming in, they're 33, but they have a family history of someone that had at 43. I should actually be having this conversation with them now, even though I'm, maybe used to having some people who are approaching 45. So I agree that is a fantastic time to have it. If you're approaching that age and if you have a family history, but I will push back and say that I think this is something that should happen, period, because it's becoming such a big problem that people, like, I think a question should be for annual visits: do you have any of these potential symptoms for CRC? And it doesn't have to necessarily be say CRC yourself, but it's just, you ask these questions, 10,000 questions. One question say, do you have any blood in your stool or something? Because a lot of people, again, they just don't know. And then by providing those answers, you may say that the provider can actually recommend, a stool-based exam or something for that patient. It's a good
Appreciate
question.
that. I was gonna say that's a great question. Also, we have more than 5 minutes. I don't even know why I said that, so sorry about that. Next from Laurel, what methods have you found are most effective for closing the gap between positive results and completing a colonoscopy?
So what I've learned is that one shoe doesn't fit all. And so what I mean by that is, I'll give an example of, I used to live in Minnesota, and, God bless them at this time. I used to live in Minnesota, which has the largest Somali community in the country. And, thanks to data, you can actually see how disparities look. So, I mentioned earlier about the national screening rate, a few years ago in Minnesota, it was looking great, 70, percent, but no one met that except whites, about 72%. Blacks were like 55, American Indians were like 54 or so, but Somalis, they used to be like 28. And so I was like, why are their why are their screening rates so low? And so I did some work, and this is out published. And so, I did these focus groups with eligible men. And when I did these focus groups, I first did them, partnered with a community leader, and we were respectful of prayer time, and we had food that they could eat, and we had incentives. And when we had the focus groups, it's supposed to be an hour and a half. Well, the first hour, these men could not complete the consent form that was translated in English and Somali because they couldn't read. So I was like, oh, okay. And so thankfully I had, scholars in my lab that were able to translate that to them. But that took a whole hour. So now I got 30 minutes to go through these questions that I had planned for, and now, for quite some time. And then as I'm asking these questions, they're asking me questions. And I'm like, wait, I'm supposed to ask you questions. You're supposed to ask me questions. But they were so upset and concerned about seeing so many of them close pass away from colorectal cancer that they wanted to know more about it. And so I can talk about that for a long time, but I'm just using this as some of the barriers that can get into, that we have to overcome in order to ultimately get a positive result to even complete a colonoscopy. And so some of the things that were keeping them from even getting screened were feeling that cancer is something that resulted from you being disobedient to their God, which is a lie. Another one is that they can't distinguish between the different types of cancer. So they don't know the difference between colorectal cancer versus prostate cancer. And so even to do that, trying to consider interventions where it may be a faith leader that is leading the conversation and making it something that's common knowledge, because something else that came up was that prevention is something that's not big in their culture. Like, you go to the doctor when your eyeball falls out, not for some preventative screening. And so learning how to make sure that we are coming and meeting communities. So again, making sure that we're meeting communities where they are as much as possible, whether it be their culture, their sexual orientation, etc. That's how we ultimately close the gap between positive results and completing the colonoscopy.
Thank you for bringing that up. Yeah, I think cultural nuances are something like super intense that we have to figure out and like just make sure people understand. And yeah, like the educational part and reading and literacy, health literacy in general, it's tough, especially if it's in different languages. So, going on to the next question. I'm doing my MPH capstone on EO-CRC. How do we relay the seriousness of the disease to young people, especially given the amount of contaminants in our daily lives? Yeah, I literally have this conversation with Cecilia, like not all the time, but I'm like, yeah, like the young people. We talk about the TikToks, so like how like this is all mentioned all the time. So about CRC getting into young people. So I will let you answer the question now. Sorry.
Yeah, so you gotta be creative. And so again, it comes back to meeting people where they are. And so I mentioned briefly about the hotspot work I've done and the lived experiences, but more so that media campaign, like with CRC and me, which is still live now. And so I dropped it in the chat, and then I'll also try to share real quickly so you can see. So this was informed from the hotspot data to find where we're going to target younger people. But the framing, what we ended up doing, came from the lived experiences, and we actually had a early onset patient survivor panel that were consultants on this project to help us ultimately choose this. We had one graphic that was like a before image of a family having a party, and the other one was the same family at a funeral grave site. That one did not win, but this one did. And the idea was that younger people, they text a lot, and so everybody knows the poop emoji. And so you can see we use the poop emoji to say that this poop has never been so important. Colorectal cancer is now affecting 18 and 49-year-olds. Pay attention, get screened, assume your role, like the role of a toilet tissue. And so with this, we not only were trying to, the call to action was driving people to the site to, learn about some of the symptoms, the risk factors, how it was the number 2 killer, how, back then it was be the leading killer by 2030. Again, that's now the case today. How it's preventable with a colonoscopy, the recommended screening age. If you have a colon, you can develop a colorectal cancer, et cetera. But how we targeted the younger people was everywhere. So this was on like billboards on major highways that they may drive down in a community that was indigenous or American Indian Alaska Native that was didn't have as many billboards. We found one that was like in the woods on a road that everybody passed. To make sure we were reaching that population where disparities were really high. As you saw from my slides earlier, like we were in bathrooms, and those bathrooms were like at like nightclubs and bars where young people went. Say I go over here and I go to Macy's right now. I can look for another blue jacket so my brown one don't fade out on camera anymore. We were targeting people that had risk factors for early onset CRC by what they were searching on the web as well. And so they go back to Macy's or they go to Facebook and a little ad will pop up for CRC and me. This poop has never been too important. And so in brief, we got to get strategic, but also innovative in terms of how we reach young people. But also, my biggest thing is working together, because I believe that team stands for together, everyone achieves more. And so since you are in your journey and we want you to actually graduate, partner with people who are already doing the work. Several of my colleagues are in DC right now, planting flags that represent the number of people that are expected to die from colorectal cancer, early onset colorectal cancer by 2030. There's so many different advocacy organizations. I even have one that are out here actually trying to make an impact. So you don't have to do this alone. Be creative, partner with other people, and thank you for the work that you're doing.
Thank you. We have a few more. We have a lot of questions coming in, and I'm very excited about it. Our next one is, can you talk some more about engagement versus outreach? We have a centralized team doing texting and phone calls. Are there any key steps that you recommend?
Can I tap Cecilia to answer this? Or no? I can't phone a friend.
I'm sure you can, Cecilia, if you're in the oh, I can bring her. Hold on, I'll bring her on stage. Yeah.
I am here. phone a friend. It's a possibility here. I'm around, but yes, there are interesting ways, and I don't want to steal the thunder from the session we have later today with our wellness co-pilot, but I've spent a lot of time looking at the different ways that our health centers and our clinics just broadly are using, of course, in our case, care message and text messaging. But what you'll see in our wellness co-pilot is sort of an expansion of a messaging approach that will give you more avenues to handle more of that complexity of what different patient journeys can look like at different stages. And so we will be releasing one new program that's early education, so that hopefully our clinics can start to do at least an annual campaign with younger patients about reasons you might want to get screened earlier, early signs to look for, what screening options will look like. So we'll have a series of automated campaigns around that. The second set of programs are going to be looking at different potential cohorts to support. So supporting patients in selecting screening options with the ability to also segment out between high and low risk patients, and then additional segments for follow-up with patients who may have received an at-home kit. So whether it's a fit kit or Cologuard, to help them complete that, and also navigating some of the troubleshooting that happens in between. And then the last cohort is for patients who may have had an at-home test with some abnormal results coming back, and sort of some of the troubleshooting around the patient navigation that should come after that as well, to get them connected to resources or better understand the barriers that they face to getting a colonoscopy. So we're working on more, I'd say, automation and deepening of automated conversations that supplement and allow you to reach more patients and bring them back into segmented cohorts that the staff can then follow up with, depending on the action that that patient is hoping to take. And so in each of the programs, you'll have the ability to, give patients the option to, for example, request a phone call. Maybe the way that they want to decide on their screening option is to have a conversation, with your staff or with a provider. So we're helping support just the segmenting and the navigation of that, and doing that in a more structured way that's been informed by what we've learned from all the engagement that our clinics have done on our platform. But we did have last year almost 1 million messages that went out through our system about colorectal cancer. So it's given us a really interesting source of data, and our hope as we're releasing our co-pilots in these new programs is actually will be to have Dr. Rogers back and help us continue to evaluate the successes as that engagement is happening, and help inform future iterations as we continue to gather more data and learn more.
Thank you. I hope that answer. I don't even remember. There's so many questions coming in. Annie. I hope that answered your question, Annie. I am going to remove you now, Cecilia. Appreciate you so much. We're gonna give the mic back to.
Thank you so much. You did great. You did so good. Thank you so much.
Okay, the next question we have from Emily. Do you have any resources or recommendations for those who are for those who are uninsured and afraid of the cost of a colonoscopy?
Awesome. So I tried to respond. I don't know if I did. Oh, no, I didn't. I responded to another question in the chat. Someone asked about like people who can't get time off, and I recommended providing options in the evenings and the weekends. So with this question, I see that we have a comment from Kendra, and she actually noted that Cologuard and their patient assistance program could be a great way to get those who are uninsured initially screened. They'll cover those up to 400%. Beyond the federal poverty level. And I think that Cecilia earlier today also provided some options in terms of financial support from the Alliance, Colorectal Cancer Alliance. And I think there are a few other programs also that also provide, things out there. But I'll also add that there are several less invasive options that are more cost friendly. stool-based exams that you do in the privacy of your home. I've done a lot of work with in terms of men and how masculinity is a barrier to them. It's less invasive. You do the privacy of your own home. You don't have to worry about taking off work, and they're fairly accurate. And even some organizations, including my foundation, we do offer free stool-based kits as they're available to anyone ages 18 to 75. So I will say that we remind these individuals that the best screening is the one that gets done, and colonoscopy is indeed the gold standard because it actually can remove polyps before they actually turn into cancer. But there's some other options that we can get people just in the door who may be uninsured or afraid of the cost of a colonoscopy.
Perfect. If anyone has any other questions in the chat, I see other people are responding. Heather, in addition to what you answered to Heather about addressing the lack of paid time off, can you drop these financial assistance options into the chat? And then she also said, we are purchasing fit tests, but we are having trouble getting colonoscopies for uninsured patients.
So Heather, when you say that you're having trouble getting colonoscopies for uninsured patients, you're saying you're having trouble getting the people to complete them or the funding for them? The funding. Oh, I don't have the power to talk about money today. If I did, I would just send some money your way. So I'm gonna have to tap out on that one. Because I think that's a whole nother that could be another care message summit in terms of overcoming the politics related to everything. So yeah, I don't have a solution for that. I do have one idea. So there's been a lot of turmoil in America, but there used to be these, programs with the CDC where they would provide funding to health departments and things of that nature. And a lot of those have now been did away with. So another option may be for you all to actually partner with some gastroenterology specific organizations near you, because they tend to often donate a certain number of colonoscopy a year. And so I've had great relationships with some where like I've looked at the data for the uninsured rate in different states that I worked in. And I said, okay, if I'm trying to get 50 people in my study, the uninsured rate is 10%. Okay, can I get this GI organization to donate 5 colonoscopies so that I can make sure I can have, try to get people through the process in terms of that may have issues that may like for being uninsured. And so that's the only option that I can think of right now. If someone else has them, they can definitely drop them in the chat.
I appreciate you mentioning that. I'm sure like a lot of individuals didn't even know that they can partner with GI teams. Stephanie, I think just added to kind of assist with the question. We usually have to connect with patients, or usually have to connect the patients to the financial assistance programs at the provider completing the colonoscopy, unfortunately. So I don't know if you have any additional thoughts about that, but yeah.
No, I do know personally some providers that will donate their time to get people. And so even I mentioned earlier, there was a program that started out in California several years ago. They called them Super Saturdays. And so they would do a whole bunch of colonoscopies on Saturdays for people who were uninsured or didn't have, had limited availability, as someone mentioned earlier, because of work and things like that. And that was ridiculously effective. But it was a lot of people working together to make those things happen, because you had to have anesthesiologists and you had to have the GI and you had to have the facilities and stuff. And a lot of that stuff was donated, but a lot of that stuff can be, written off, and everyone is doing some type of charity work every year. And so that's something that they definitely can, consider partnering with organizations to see if that is an option to move forward with.
I appreciate that. Yes, that's a good idea. Super Saturdays. Awesome. So we are just about at time. I appreciate all the knowledge that you've shared with myself and the audience. Cecilia also just mentioned that one of our previous panelists mentioned that they are testing engaging medical school students to provide colonoscopy. So that's really cool. Yeah. And Stephanie just suggested that they work with a state program that covers colon cancer screenings. So maybe there's an option in your neck of the woods. So please check that out if you haven't already. And yeah, so Dr. Charles, you're the best. Appreciate you. You are an OG. Love that. Love everything you do. And so if anyone else has any questions, please feel free to drop them in the Q&A portion. And we'll send to Dr. Charles to check out later on and have that recapped in the